Meanwhile, request Dr. Anand PARTHASARATHY to please. Dr. Anand PARTHASARATHY is going to speak Smile All the Way.
Can you just, Dr. Anand, smile. Just to answer that for the doctor is that it's a good way of marketing it, because there will be a set of patients who would opt for budget, there would be premium and luxury. So it actually helps to kind of diversify. Thank you, Dr. Vinod, Dr. Dhami and Monica, lovely to be part of this session again. No financial interest, but it would be good to have some. I think in terms of understanding the smile procedure, you have a femtosecond laser application, you have a small incision creation, you have lenticular extraction, and then of course you have natural healing. The natural healing basically is altered without the flap creation, and that is the fundamental difference in terms of smile versus LASIK versus PRK. There are some mild procedural differences. A smile is a single femtosecond laser lenticule. It's a small 2 to 4 millimeter incision. There is no flap creation, minimal nerve disruption, preserve biomechanical stability, and suitable for thin corneas and dry eyes. The LASIK requires 2 lasers, requires a large flap creation, significant nerve severing, greater biomechanical impact, restricted in thin corneas, and can exacerbate dry eyes. Smile's flapless procedure is a significant procedural advantage which preserves the corneal integrity. Now, you look at the meta-analysis of almost about 18 comparative studies, wherein you compared Smile, PRK and LASIK. You had an excellent visual outcome, superior or equal to LASIK, and at 6 months, 95% are 20/20 or better compared to 93% with LASIK. The long-term follow-up studies demonstrate a superior stability of smile versus LASIK. Mean regression is only about 0.1 diopter for smile compared to 0.8 diopters for LASIK. So both in terms of long-term stability, LASIK is slightly lesser than smile. What about astigmatism correction? Important part, because you get myopic astigmatic patients. 94% for smile, 92% for LASIK, within about 0.5 diopters of targeted astigmatism. The mean difference between LASIK and smile is only about 0.1%. So astigmatism probably very, very similar. What about corneal nerve preservation? Important part, you got a faster recovery in corneal sensation with smile. Tear production is better preserved. You have patient comfort, you have nerve disruption, which is 60 to 70% with a LASIK and only about 10 to 15% with smile. This has been confirmed by corneal confocal studies which preserve that the architecture of nerve is better preserved with smile. And of course, the small incision also helps comfort post-operatively. When you looked at the incidence of dry eye symptoms comparing smile with LASIK, the smile nerves, because they are less cut, the incidence of dry eye is significantly lesser with smile. Objective dry eye measurements, when you look at tear breakup time, Schirmer's or corneal staining, the smile definitely scores a lot better. Now, in terms of visual quality outcomes, which is contrast sensitivity, night vision quality, and higher order aberration. So smile shows 12% better preservation of contrast sensitivity, better night vision quality, and 18% lower induction of spherical aberration with smile. This is based on multiple studies. You looked at a wavefront analysis study published in JRS and found that smile induced fewer higher order aberrations, particularly spherical aberration and comma. An important part is about corneal hysteresis, tensile strength, and residual bed strain, and this is through corneal modeling, which is basically indicates that the strength of the cornea post smile surgery is better than LASIK. The flap versus flapless, very common point for discussion is in terms of subclinical applications, which is microstriae, interface debris, epithelial ingrowth. Minor complications like flap displacement, edge irregularity and dry eye, and major complications like flap amputation, buttonholes, and infectious keratitis. Post-LASIK ectasia, definitely a vision-threatening complication, and you can occasionally get very severe striae or very occasionally a free cap. But almost about 1.8% of LASIK procedures compared to 0.3% of SMILE procedures have complications. I'll then come to the surgical technique. This is a patient where you have a dry surface, not ideal. What you're looking for is a perfect laser pattern during surgery, and I'll discuss the surgical technique more in detail. Docking, always adopt a soft dock approach. You got to activate suction at about 70% applanation, check for pupil centration before you go ahead. So this is the procedure. You got the in view and you got an additional camera to check the applanation, and now you got a very perfect dock. You got a cut which is very centered on the pupil, between 8 to 20 seconds depending on machine that you have. The lenticule dissection technique is basically an inner circle represents a lenticule, the outer circle represents a cap. The space between the lenticule is about 0.5 millimeters and the size of incision is about 2.5. The anterior pocket must be dissected first before proceeding to the posterior pocket. So the superior pocket opening is important because you got to begin by opening up the incision, stay within 0.25 millimeters of the cap, within about 0.25 millimeters the open incision on both sides. This ensures that there is a plane which can dissect the anterior. So this is just to demonstrate that. So you open up, this is of course done under topical anesthesia. You got to do it early before the bubbles disappear. So you use a separator, you go only in the anterior part first, and then you attempt the dissection of the second part. Your inferior opening is important because you got to avoid going in the wrong plane. So once the opening of the anterior pocket is delineated, we now move the instrument in the posterior pocket. Just make a 0.5 opening. There are something called the ridge sign where you can make out the lift of the stroma before you actually do that. So you've done the anterior, now you're going to go for the posterior part. So this, you're going under the cut and now you're lifting up. So now just to make sure on the posterior part, you'd go across the pocket to make sure both are not connected. Now you've got the anterior plane and the posterior plane. You can now switch the instrument to the dissector, complete the anterior dissection using swiping movements. So this is the curved dissector, and if you are a lamellar corneal surgeon, this works out quite easily. So you go anterior first, go to the full length of the dissection and do it in a gentle swerving motion so that you do not disrupt much of corneal fiber. And this has to be done gently. There is of course a fear that you would perforate, but usually if you do it gently, do it bit by bit, go to the edge of the dissection all the way where the dissection is done. And now you have dissected the anterior part. In the inferior dissection, you enter the posterior pocket now. You got to move as close to the border as possible. So how this is done is you use your dissector, go under the plane you've already created. You will feel a bit of resistance, and then go to the edge slowly because this is in the visual axis. So dissection over the visual axis has to be done a lot more slower. Go to the edge of the dissection. You will have a bit of resistance, and you got to push through the resistance. The edge dissection is important because once you've completed the anterior, the central, posterior, move the instrument from 1 to 5 o'clock and the edge is dissected in these clock hours first. So this is just a video to demonstrate that. You make a edge, you go beyond the edge of the posterior lamellae, you go on one side first, you leave a bit of the, now you go to the other side. Now you got about a central island which holds the lenticule in place, and you do the second part of the dissection on the left side. So you go to the edge, you can make out the edge of the lenticule is perfectly delineated. The lenticule extraction is the final step. When done correctly, the lenticule is intact and not folded over. It's now ready to be removed with a forceps. So how you do that is you clear that central island. Now you've got a free lenticule. You then use the forceps. Just ask the patient to look down a bit. That's actually a good idea. You have a curved forceps. You go under, just kind of free it. So go anterior first, go down first, then you come out. That helps to free the dissection very well. And of course, you can make sure that you got the complete lenticule, not really important. You can hydrate, some people don't. And then once you done that, you can actually just oppose the edges. So I do this, which is the flattening on the horizontal and vertical meridians, just to make sure the stroma is opposed. This is just to show the procedure. You always center it on the pupil. The 800 has some kind of a tracking wherein you can actually make it out. This is perfectly centered. Patient looking right inside the eye. You complete the dissection. Usually takes on the older machine about 20-22 seconds. On the newer machines is hardly about 8. There are of course some complications with some diseases, which is basically suction loss, black spots, wrong lamellar dissection, some folded over lenticule, torn lenticule and retained lenticule. I would not go into all of that because that would be a separate lecture itself. The causes for suction loss are inappropriate cone size, the surface is being too wet, poor cooperation and improper docking. You can get suction loss even in this femtosecond procedure because the suction amount is slightly less than a microkeratome. So you have to be, you need a cooperative patient because the amount of suction which is present with this is significantly less. Sometimes if the patient is very tense or squeezes too high when you're actually doing the applanation, that can cause it. Sometimes you see these bubbles coming around, that means the eye is moving and you're not able to get good suction. So you would need to redock and then reapply. If you have a suction loss, you can still go back and either you can wait, you can go deeper. If you've already cut, you will need to at least wait for about 15 to 20 minutes. There are of course some retreatments which can be done even in this if you have the previous parameters. I would not touch upon that. Black spots are sometimes because of suboptimal energy settings and service being too dry. Long lamellar dissection easily rectifiable by finding the anterior pocket. Usually in the first 10 cases you'll be able to you'll have slightly more difficulty. After that it kind of settles down. The learning curve for SMILE is probably 8 to 10 patients, I feel 8 to 10 eyes. And sometimes the problem is always in the initial insertion. So you go posterior first and then you go anterior. A lot of times you will have a problem. So in this you can make out that if you look very carefully, the posterior lamellae ridge is actually seen, which is important sign that you are actually in the posterior part now. I would not touch upon this. It's actually more unusual. If your dissection is done properly, you will not have folded over lenticules. There are some SMILE specific complications. Usually difficult lenticle extraction is about 1.9%, and on the early learning curve, which is about 10, it's 4.3%, and experience probably about 0.8%. There are lenticle tears, which is about 0.7%. Enhancement is about 2% compared to 3.8% for LASIK. This is just the complication rate when you compare intraoperative, early, postoperative and enhancement. Vision threatening complications are also quite significantly less across all procedures, but intraoperative probably more with LASIK compared to SMILE and PRK. So in terms of patient satisfaction, if you look at multiple published studies, the satisfaction is slightly higher for SMILE compared to LASIK. The long-term follow-up, 5-year outcomes in terms of stability, both are beyond 90%. But when you look at 5-year data, there is a bit of myopic regression, slightly more with LASIK. The ectasia risk is both are less than 1%, but SMILE is significantly lesser. And the risk factors are similar for both: thin corneas, abnormal topographies, young age, and high myopia. In special populations or in active sports, it is actually probably the preferred option. Thin corneas with respect to especially preserving the biomechanical strength, and it's probably a good alternative to phakic IOLs. Military and first responder applications is something that is also a preferred option. So future directions include faster lasers. They are now looking at topography guided SMILE. Hyperopic span still in early development, maybe a challenge I feel. Automated extraction, some kind of robotic assistant, which is something that is being thought about and worked on. So key takeaways: why SMILE leads modern refractive surgery. 95% patients get 20/20 or better, significantly reduced dry eye, enhanced corneal biomechanics, elimination of flap complications, and superior patient satisfaction. Thank you so much.
Thank you so much for a very, very illustrative presentation, Dr. Anand. Dr. Anand, in LASIK we see the wow factor maybe after 5 to 6 hours. How does it happen in SMILE? I think the results are pretty good. But
I think better positions, what you're saying is correct. So the recovery does take slightly longer. I think that everybody accepts. In the 4-week follow-up, when you compare SMILE and LASIK, both are very, very similar. So I think you need to warn the patient, and we have seen patients operated where they are unhappy with the initial visual recovery because of all the ads, 20-second procedure, you're going to see everything well. So I think we have to undersell the visual recovery, but oversell the safety.
No, I differ here. Dr. Anand, we were just discussing, I told you we'll discuss it later. The visual recovery with the SMILE Pro, that is a faster laser, is 6.5 very next day. I am yet to see a patient which is not 6.6 very next day.
Interesting.
Still a wrong refractive error has been felt.
Very nice. So
That's why the wow factor of SMILE Pro is much faster.
and you think it's because of a faster laser?
It is faster laser because
So the faster laser helps in easier dissection, and that helps in Bartok.
Yes.
I think the machines are improving.
Yeah.
Yeah, please.
So, I mean, as of now, you know that there's no customization in lenticle procedures. So don't you think that that is a bit of a drawback?
For astigmatism or you mean in terms of power, sir?
No, not in terms of power, but in terms of topography, and now that even
Topo guided or
I think I mentioned that, so they're working on topographic guided SMILE.
as of now, what do you feel that?
See, if you have, in my opinion, so there is a subset of patients who will always do well with a wavefront guided treatment. These are patients with slightly irregular corneas, who are borderline frost, who have varying amounts of refraction. You can do SMILE extra if you are confident, but I take these patients up for a topography guided laser. I have a fairly good keratoconus practice, so I have good experience of these wavefront guided treatments, for topography guided treatments for these specific set of patients who do not fit into the normal range. So if you look at what is the normal range, I think 90 to 95% would fit into the normal range where SMILE will work well. There is a subset of 5 to 10% where you need to take a call. If the refraction for these patients 6x6, SMILE would be a better option. Sometimes a lot of these patients are 6-9 parts, they have slight irregularity, astigmatism not the linear one, they may have slight asymmetrical bow tie. Those may be a good option to consider topo-guided PRK or a trans PRK, which work equally well in terms of the final visual outcome.